Much again, Shrenik, for the invitation, and it's a real pleasure for me to be here with you. And I will share my experience of after 30 years of experience, I must say, and more than 3,000 cases of laparoscopic case, and more than 1,000 with robotic case. So at least 4,000 cases of radical prostatectomy. So it's a large experience, and it's great to share this experience with you. So first thing, I want to talk about this, but there is different access. You see the transperitoneal approach with the first dissection of the seminal vesicle described by Richard Gaston, the reduced pairing, the anterior access or the lateral access, and you have seen this morning the extraperitoneal access. In fact, there is no difference. It's the same surgery, and what you have to do is to go on. The installation of the patient when you are doing retroperitoneal access is easier because you have less tremor to let to the patient. So it can be quite 10 degrees, and you will use see that I'm using a pneumatic arm to hold the camera. So this is a pneumatic arm which I use. So it's from Esculap company. It's under pressure. You have just a small button, and you can place the scope. You see the scope. The scope is fixed. In fact, you have the scope fixed, and you can have 4 active hands. That means that you are only 2 surgeons, one surgeon, 1 assistant, but 4 active hands. And you see, I'm sitting on a saddle. I'm really comfortable, and always it's very important to have to do this smart laparoscopy, as I said. Okay. So for the position of the ports, it's symmetric. One is 10 millimeters at the level of the umbilicus. One is 10 millimeters, about 2 fingers above the pubic bones. 5 millimeters for the pararectal line. Because I'm left-hander, I will work on the right side of the patient. So that means that my assistant will be on the left. So I will add another port for the assistant. But if you are right-hander, the assistant port will be on the right. So to create the pneumoperitoneum, you have seen this morning. But if you have not seen very well, I will re-show you again. You just do a puncture. The bladder is empty with a Foley catheter. You just do a puncture 2 fingers above the suprapubic bones, and you will inflate this space. And you will place at least 1 liter of gas. And you can see clearly that the abdomen remains empty, and just the reduced space starts to inflate. When it's done, with your optic trocar, it's a 10 millimeter, you will do a chicane pathway. That means 2 centimeters under the skin, and then get in the space. And if you do so, you will enter immediately in this arachnoid space, and you will do as you were doing with open technique, like if it was your finger, your scope is like your finger. You just stay in this layer, and you just open, and you just create it. You can see laterally my movement. It's just a movement to create, and you just stay in this typical aspect. And you will find immediately in front of you your first landmark, which will be the Veress needle, because it's straight. So you see this first landmark, and then you enlarge. You will find the second landmark, which will be the pubic bones, because what is important is in retroperitoneal access is to have landmark, because if you have no landmark, you will be totally lost. So you see the second landmark very easily, and now you have to detach laterally the peritoneum to be able to work in this space. If you just start now, you have not enough space. So here you will go laterally, and what is important here is the epigastric. And we talk about how to get more skills. What is important is to know the anatomy. If you know perfectly the anatomy, everything seems to be simple. So you see we are on the left side, and you see here, slowly, I'm looking for the epigastric, and you see it now. You can see it very well. You see the epigastric, okay? And when you see the epigastric, you have to let the epigastric attach to the abdominal wall, okay? You have not to go there, because if you go there, you will detach them. You have to go under them. And if you go under them, then immediately you will find the muscular part, the transverse muscle, and immediately you will find this. And then what is important is to go at least at 90 degrees to free and to release totally the peritoneum pouch. So you see this attachment, okay? And now you go and you follow this part. You see the epigastric. You have to enlarge, because here it will be important for two things. First, to place the prostate at the end of the surgery, and also to have possibility of suction, because then it won't collapse the space. So you see, it's done now, and you do exactly the same on the opposite side, and then it's done. So concerning the strategy, when we were doing the open prostatectomy, it's a vertical view, so it's logic to start by the apex and to do a retrograde prostatectomy. I have tried to do this surgery in 2001, because I started in 1998 when Richard Gaston described by the first approach of the seminal vesicle, but I have some trouble, and I stopped for 2 years, and I redo open for 2 years, thinking about this technique. And then I said, oh, perhaps it's possible to do the radical prostatectomy by the same approach, retrograde. But in fact, it's not logic, because when you have to deal with the apex, you have to deal with all the problem. The sphincter, the urethra, the positive margin, the rectum, and the bundle, and the bleeding. But when it's done, then it's finished. You just retract. So, in fact, it's totally unlogic. And when you are doing laparoscopy, you have to follow the light. The light is coming from the head, going to the foot. So you have to follow the leg, and so you have to go from the bladder neck to the apex, and not so. And so the logic surgery, for now more than 22 years in my habits, is to start by the bladder neck, and then slowly, like step by step, you will do the third one, which will be seminal vesicle, then opening the denovial fascia, then doing the bundles, mobilize the prostate, and in fact finish with what was the most difficult, finish with the apex. Okay? You have to think about ergonomic position, because we are talking only robot. I was sitting on a saddle for 1997, so it's quite 30 years, okay? And because I was thinking about my position of my elbow at 90 degrees to be... I was using a pneumatic arm. I bought it in 2001, so 24 years ago, okay? So just to say, because I imagine a fixed image, just to work, because the prostate is always medial, and you just place in front of the scope what you have to do, instead of moving. It's a... robotic instrument is possible, and also the 3D vision, it changed totally. We bought it 8 years ago. I can't do any surgery without 3D vision. And it changed everything. And if you have this quality of surgery, then you don't need to have the robot. So this is possible. I don't use anymore, but you know perhaps this kind of tools. It was a French company, now Dexterité, but it's possible to use it. And you see it's possible to be comfortable. You look how I'm working. I am on a saddle, and you look my elbows, look my hands. I'm totally comfortable. Okay? The 3D vision, mandatory, okay? And now we'll describe step-by-step procedure. For the opening of the endopelvic fascia, it's not always. But I think when you are young, I think you have to do it, because you will see much better the bulk of the prostate. And with experience, you will stop, and then you can just incise in front of the puboprostatic ligament and just try and to spare everything. But I think at the very beginning, open the endopelvic fascia, you will see better, and then slowly you improve your skill. So first, the bladder neck. We have just created the space, we have just placed the ports, and we start at the level of the bladder neck. You will see here in this patient, on the left side, no positive biopsy. So I didn't open the endopelvic fascia on this side, and on the right side, the tumor was a little bit bigger, so I have done already the opening of the endopelvic fascia. So I start always medially, and what I'm looking for is to try to see the urethra immediately. And you see that the pedicule are always, this is not the neurovascular bundle, the pedicule, the vesicoprostatic pedicule are just on both sides. And you see that slowly you can just try to find the good space, and slowly I will go laterally to find this space laterally. So for this, what is important is to let in the balloon only 3 cc of water, not a big part. And you see here slowly with traction and contratraction. What is very important is your assistant. You don't see my assistant. He has 2 active hands. One hand is doing the traction on the bladder, and the second hand is with the suction. And always, when you will do this surgery, you have to know that it's a teamwork. So you have to know exactly what your assistant must do. So here it's not the bundles, neurovascular bundle, it's just the vesicoprostatic pedicule, very small bleeders. And this is done on the right side. And on the left side, you see here, very important, sometimes you see some vessels. These are pudendal arteries. If you see a vessel like this, try to spare them, because sometimes these vessels are the main vascularization of your sphincter, and if you cut it, sometimes you have bad results just because of this. So you see the exposition. My assistant is lifting here. The suction device is doing suction but also exposing. And then I'm doing a V incisions. I mean that I'm not straight, I'm going posteriorly here to find laterally the seminal vesicle. You see how important it is to expose. This morning I've done a hole here because I was not well exposed. It's not a problem, you can repair, but if it's better if you can avoid. And you see, immediately you can see posteriorly, you can see the aspect of the seminal vesicle. You have the posterior layer, and you will finish at the level of the bladder neck. So I like to do like this in 90% of the case. So when you have a median lobe, when you have previous TURP, then I will start medially. I will open the bladder. I will take the median lobe medially, and I will open the posterior aspect and finish. But then you have a large bladder neck. But if I can, I will always try to spare. And with the median lobe, you can spare bladder neck, even with median lobe, by the retraction. So you see, this is the aspect at the end of the dissection. You have this typical aspect, and then you can cut, and you have not to look at the urethral orifice, because they are far. So this was the first aspect, and this is the second aspect, and then it's done. Now it's time to do the Donnervilliers fascia. It's very important. You see my assistant will lift up the 2 seminal vesicles. There is a problem because, excuse me, I have done mistakes. This is now. This is the two seminal vesicles, okay? So we start by like this. So we have to open like this. And you see the assistant is lifting up the bladder, the prostate, and then we go behind. And I like to start like this. I mean that you see the vas. Inside you see the seminal vesicle, and then here you have this layer. You just have to get in this typical space And this is the Denonville fascia remain intact. And then you have like a wheel, and you can now inside the seminal, the vas deferens. Always you have the pedicule. The pedicule is always outside of the vas deferens, so you can do small coagulation. You have to cut the vas. You cut the vas. So this time is not difficult time. It's really well codified. You see my assistant now will come and she will grab the seminal vesicle. So everything is codified. You must know perfectly what your assistant has to do. If I was doing it with the robot, it will be my fourth arm doing this. Okay? You see the grasper, and you see the image is totally fixed because the scope is fixed. So we just place in front of the scope what we want to do. So here, it's the beginning of the pedicle. I will place hemlock clips. And the orientation of the surgery is to reach the previous hemlock clip. So we will go like this, just following. And my assistant is just lifting up and showing me what I have to do. So you see, she grabs again to take out the seminal vesicle. It's possible to let the tip of the seminal vesicle if you want, but most of the time I remove it. You see again, up, she removes. We have not to speak. She knows perfectly what she has to do. And now it's done on the. Now it's done. So you do exactly the same on the opposite side, and that's it. I will show. I have done a small mistake. Excuse me. So okay. So now it's the time of opening the Denonville fascia. So now you lift both seminal vesicle and what is important, as I said this morning, is to let about 1 centimeter. You incise about 1 centimeter because I will use this part of the Denonville fascia to catch it, like a membrane, like a solid membrane. Okay, and you see here the fat. It's a prerectal fat, and you see I will give it to my assistant. This part. It's very solid, and then I will just have to find now. Now you have to pay attention because the rectum is really close, and now I will go as high as possible to reach the prostate. You will see the prostate somewhere there. So the rectum is here, the prostate is here, you see the bulk of the prostate, okay? And now you start really the dissection. And you see my mini clip, as I use, it's like a grasper. You can grab something, and when you think it's okay, you can place a clip. It's really effective. And you just enlarge on both sides, and now it's the time to dice, to start the nerve sparing. So for the nerve sparing, it depends on what you choose with your patient before, and it depends also on the biopsy, on the MRI, etc. For example, if it's a very large tumor, you have to do a non-preservative surgery, so you will be at the level of level 1. Most of the time, what we recommend is an interfacial surgery. That means that you let a small fascia in contact with the prostate. But sometimes you can imagine to do really an intrafacial surgery if the patient has, for example, no positive biopsy on this side, if he has a young woman and he wants to recover a very good potency. So you have to decide before the surgery, okay? How to get this space? This space is the most difficult time. And with the 3D vision, it's more easy, but you see the assistant will lift up the seminal vesicle, and what you will do is to dissect from inside to outside to dissect the bundles. So you see the assistant is lifting up. I'm on the right side. You see I am with this mini clip from Esculap, and then it's just like this. Clip, scissors, and it's this clip. You see now perfectly the bundles. And on this side, as I said, I had opened the endopelvic fascia because the tumor was huge on this side. So it's a interfacial surgery here. So you see my assistant is lifting up to let in front of the scope. Nothing is moving. It's just the assistant placing what we have to do. Always very important to redo central dissection, and then clip. Always redo the incision. Very important here to develop the space of the rectum here, and then slowly you turn the prostate, and then you will finish. But at the end you have to stop because the end of the bundle is going towards the urethra. On the right side you see that the endopelvic fascia is not open because I will preserve. There is no positive biopsy on this side, and also because he has accessory pudendal artery. So here what I'm looking for the contact with the prostate immediately. So this is important to find the contact. You see this white aspect, this is the contact. And now my assistant will place the clip. So I will just place my scissors to say, okay, go there. You see? So you see, I place my scissors, she knows, she comes, and we are working together. I am doing the exposition with my right hand, with the grasper, okay? And you see now, I am placing in front of the scope what I want to do. So immediately, we go, and you see that now it's really effective. And slowly, here I am intrafacial. You will see I'm very, very close because we imagine to preserve as maximum as possible. So you see perfectly, you see the gland of the, and here you can't do the surgery if you have positive margin or if you have a positive biopsy. But if you want, you can do this surgery for really, really important preservation. So you see here, go on. And you turn, so you see here you have a typical aspect of artery penetrating the capsule, so you have to cut it, because if you don't cut it, you will have a positive margin. And then we arrive at the level of the apex. So it's quite finished. You see the puboprostatic ligament on both sides, and now it's quite finished. So as I said, at the end, you have to stop the dissection, because if you go on with the dissection, then you will transect the bundles. You have to do the dorsal very complex, and then to mobilize the prostate, and then you will be able to finish this 1/3 of dissection. This will be the mobilization of the prostate. You see that now I'm coming very high, and slowly we dissect, try to spare as maximum. You see the bundles, slowly the bundles are going far away, and really no cautery, you just cut and pull down. You see, clip, small clip, and you push. And then slowly you see that the bundles is going far away from the urethra, and now you have to deal for this. If you want, you can place previously a thread. Personally, I don't place previously the thread now. I was doing in the beginning of my experience. I think there is no mean. I don't place more pressure to the cavity. I just ask the assistant to try to stop to do big suction, because if you do big suction, then you will have more bleeding. For the apex is the last key point. It's a very important point, because to have incontinence is remain a big disadvantage, and that's why radiotherapists are so active now. So we have to show them that we are able to have 99% of continence. Huh? And how to do that? To do this, you have several procedures. You can preserve or reinforce the bladder neck. I think it's important. When I was doing open surgery, I was doing preservation of the bladder neck. You can spare or reconstruct the puboprostatic ligament. You can create an anterior suspension. I've shown you this morning. And you can recreate a posterior plate. In fact, all these tricks seems to be important. All together. We don't know which is the best one, but everything is important. So we arrive at the level of the apex. So you see, now it's quite finished. So here, pay attention. Don't do traction on the prostate. If you do traction on the prostate at that time, the risk is to detach the urethra from the sphincter. And sometimes you have a very big length of urethra. You said, great, it's fantastic. And in fact, the patient will be totally incontinent because the sphincter is detached from the urethra. The urethra must be fixed with the sphincter. So you have just to turn the prostate, to rotate the prostate, just to finish the dissection. And at that time, I was placing a Béniquet, metallic guide. Now I'm not placing it anymore. I'm just using the Foley catheter, but it was possible. And here, it's a time to do the suture of the dorsal vein complex. And you see this suture is superficial. It's not going deep. Huh? It's just superficial, just to close the small vessel. You see how it is? Huh? So it's a 2O vicryl with a 26 millimeters. Huh? And just I'm doing a go and back suture, just horizontal, just to close the small vessel. Huh? And you see I'm working with 2 needle holders. That's my habits. You will do what you prefer. Personally, I like to have 2 needle holders because I like to work with my both hands. And I will, so when it's done, I will tie it and I will fix it anteriorly to the pubic bones. You will see this part will be going up, you see, and then going up, that means that it will be fixed. You see here? Yes. Very important for me. And the second thing is to add a second layer to fix together this small muscle. Because when you cut here, you have in fact some part of the sphincter going attached to the prostate. So I refix together this small thing outside of the urethra, 10 o'clock to 11 o'clock and 1 o'clock to 2 o'clock. And I fix them together, and it recreates an anterior part which will be solid. And for the time of the anastomosis, you won't have injury of the urethra, because sometimes when you have tension, when you place a needle, you can have rupture of the urethra. Huh? So you see that this part is totally fixed, and then at the end you have just to cut the end of the urethra, and normally everything is done. You just, to be able to be sure, I like to turn the prostate at the end, to be sure at 100%, and then you can't have any injury of the rectum if you do so. You can't. So you see it's finished, it's done. So we published in 2009 this article, which was the fixation. And it was an artifice. We have done pad tests before, and it changed totally. It's not 16 years ago. Okay. So we are here now, and now what is the anastomosis? The anastomosis, I will do it normally just with a V-lock. You have seen this morning. Normally, when the bladder neck is well preserved, it's like this. This morning I have to reconstruct, but it's like it's life. And then you see, I will just go, and here what is important is to get just in the urethra and not in the sphincter. So pay attention. So most of the time you see the aspect of the sphincter like a horse show. So you pay attention when you get inside. And I will, because I'm left-hander, I start at 9 o'clock but if you are right-hander, you will start at 3 o'clock, okay? And what is the most important is to start to do a perfect posterior layer, because all the leaks are posterior. And when you have a leak posteriorly, then you have fibrosis, then you have incontinence, okay? So do a perfect anastomosis posteriorly. That means that when you place the catheter, if the catheter is going behind the bladder, that means that you have to redo the anastomosis. Don't say, oh, it will be okay. No, you will have a small fistula, and then you will have bad results. So you see here, very important, this posterior plane here. And that's why now I add most of the time a Rocco to pack a little bit more the posterior part of the bladder. I will do it always when I have tension, but most of the time if possible. So you see here, it's quite finished. And you see, it's like a ballet. I know exactly which hand will do the which number. So it's like a clock, 7 o'clock, 5 o'clock, 3 o'clock, and it's right hand, left hand, forehand, backhand. There is no question. And my resident, when I let them do, I say, okay, this point, how will you do it? They must know perfectly how it is. And you see, it takes really a few minutes, because it's always the same. You have seen this morning, it was exactly the same. Here it's easier because it's my needle holder, but it's exactly the same. And then, at that time, I was placing the Benike metallic guide, but you can do it exactly with Foley catheter. The only problem with the Foley catheter is sometimes that you can pick the Foley catheter and you can be inside. With the metallic guide, it was not possible. And you see now the catheter, and you see here, I pay attention to the outside of my needle to be not too large, and then I will finish. And what is important here is to refix anteriorly at the end everything also. So that means that I will finish the anastomosis, and I will refix totally the bladder anteriorly. So that means that this part will be totally fixed. So you see, after I will refix the bladder to this part anteriorly. And again, you see the bladder neck will be fixed. We'll test, always I test, and also I test, but I wash the bladder. Pay attention to this. Sometimes you have some clots in the bladder, and sometimes in the recovery room, they call you, the patient is under retention because he have clots, and then it breaks everything. So just always pay attention to this. And you see at the end, I refix totally the bladder anteriorly to have a perfect fixation medially. And then, for me, all these small tricks helps. Now I used to place some hemostatic agent like a powder Arista in the bed at the end of the surgery. I don't let any drain, and it's over. Sometimes you have like this guy. It was 120 gram of prostate. It was the distance between the urethra and the bladder, you see, was very far. And here you should do Rocco stitches to reduce the tension. If you start immediately to do the anastomosis, you will have problems. So you see here, I will start by a Rocco stitch. It will reduce the tension. I will refix. You see perfectly the bladder neck. Here it was a huge tumor, so I have done a lymph node dissection. You see, if you have lymph node dissection, I will do it at the very beginning of the surgery, because at the end you don't want to do So if you have to do a lymph node dissection, do it at the beginning and after you do your radical prostatectomy. You see, so slowly the prostate is sliding down, and then it will be quite fixed, and then it will be possible to do the anastomosis, and I will use the same thread. So it's a 23 centimeters of V-lock. So I start by, I will go out on the left, you will see, and then I will do the anastomosis. And here, you see perfectly the muscle, you see perfectly the sphincter. Huh? So you see this aspect perfectly, and this morning we have seen it very, very well. Pay attention to this. Don't stitch the sphincter, never. And you see now, okay, the bladder is totally fixed, and now the anastomosis will be done without any tension, instead of having done, and now with the same stitch, I'm doing the anastomosis, and it's over, okay? And here, look where you get in, and you see you get out, and the sphincter is just outside. Huh? Very, very, very important, all these small details, because sometimes you have done a good job, but you are doing a bad job at the time of the anastomosis, and you have bad results, just because of small details. So pay attention, because incontinence for the patient is very, very bad. And if he has incontinence, he can't imagine to recovery, to have potency. So just wait, just pay attention to this time. I think I'm on time, so we'll just talk about some evolution. It's the end, you will see. And then you see with this kind of thing. So for me, Rocco stitch does not, I have not better result of continence with the Rocco stitch, but I think it helps to have a solidity of the anastomosis, and especially if you have, for example, sometimes you can have hematoma. With Rocco stitch, it will help to avoid to have a rupture, because the hematoma will push posteriorly, and with the Rocco stitch, the hematoma will go laterally. So you see, it's the same technique, same thing, and then we'll finish. Okay. So what is, sometimes I have to do a lymph node dissection. I will do exactly the extraperitoneal approach, like this. But at the end, what I will do to avoid lymphocele, because we have more lymphocele by the retroperitoneal access, you have to open widely the peritoneum on both sides to create a marsupialization, preventive marsupialization. But you can do, you see here, I will open the peritoneum. You will see, okay, here I open it to prevent the lymphocele. So it's the end, really the end, but I open it largely, and then you see that when some guy said you can't do lymph node dissection by the preperitoneal access, it's totally wrong. It's exactly the same. It's just a matter, and then we remove the prostate, and it's over. So the evolution, last evolution. For now, 2 years ago, when I came 2 years ago, I was not doing this. Now I'm doing rapid recovery after surgery. I'm doing outpatient surgery. I'm doing about half of my patient outpatient surgery. When I've heard this 5 years ago, I said they are totally crazy. And in fact, no. How to do it? To do it, you have to have a hyper preparation. How the guy will come in the hospital the half day. 3 weeks before, he will see the anesthesiologist, he will see a nurse, he will see a physiotherapist, he will be prepared to have a bag, he will know everything. Like if you are doing a marathon, you will prepare for the marathon. It's exactly the same. And then when he goes back home, he has everything. And at the end of the day, when we asked, do you want to go back home? They said yes. 100% of the patients said yes, and 100% of the patients I've done said we were happy to be at home the next day, the same day. So it's possible, okay? But you have to do good surgery. If the surgery is going for 4 hours, I think it's not possible. In my hands, this kind of surgery, I'm doing this surgery in 1 hour with my team. that's a median thing. Huh? So, to conclude, for me it's safe and reproducible, but I have done a lot. Okay, you have seen more than 3,000, that's why. I'm still convinced that the laparoscopy is fantastic for the prostatectomy. Pay attention to every step, because if you want to preserve the nerve, it starts from the bladder neck, but it's finished at the level of the urethra. And if you do fantastic preservation at the level of the bladder neck, but if you injury at the level of the urethra, everything will be wrong. I'm using mini clips. Huh? It remains difficult if you don't practice it. So I'm doing prostatectomy every week. Okay. It gives for me the same oncologic result comparing to the robotic and to the open when the guys are doing very well. So think to the ergonomy. I said, if you can sit on a saddle, you have a table going really down, never work like this. It's impossible. You should be comfortable. I think 3D is very important. Robotic approach. What is the evolution? Yes, probably the robotic approach is important. The problem is the cost. And the problem is the length of surgery. It takes, in my hands, 1 hour to do in laparoscopy, 2 hours with a robot, because of the setting. And so it's the same surgeon, but the occupation of the rooms is a double. Same surgeon, same surgery. So what to do? I don't know. When the patient is asking me a radical prostatectomy, I said, yes, I will do laparoscopy. If he asks me, I will do it. If he asks a robot, I will do it with a robot. But in fact, for me, there is no difference. There is difference with cystectomy. There is difference with partial. But for prostatectomy, I'm still going on with this. But I'm doing a smart laparoscopy. That means a modern laparoscopy with a good ergonomic system, with a good 3D vision, and I think it remain fantastic, and go on with this surgery, and thank you for your attention. If you have any question, we'll be very pleased to answer.
Yeah, thank you, Dr. Eric, for the wonderful lecture. We can take a few questions. We have 2 minutes.
Wonderful. Eric, by chance, during your extraperitoneal space creation or during your surgery, if there is an opening up of the peritoneum, that will be quite a detrimental thing to proceed. How do you manage at that time?
So it's a very good question, because sometimes you can have this. Normally I show you some small video, but it's great. If you have a small hole in the peritoneum while you are doing, what is important is to enlarge it immediately. If you just let it small hole, then you will have always, during the surgery, the pushing of the peritoneum. If you have a small hole, go inside with the scope, you enlarge, and then it's a mixed approach, in fact. You still in preperitoneal, but you have the passage, and it's the same. That's why I'm not talking about the surgery, because it's quite the same. I prefer to do retroperitoneally, but when I have an opening, no problem. I go on with the same way, and I'm just opening laterally the peritoneal pouch.
Wonderful. Sorry. It's a wonderful presentation, sir. So do you think using a balloon to create this space initially would hasten your initial dissection and give you a cleaner, bigger space to work in?
So it's a matter of habits. You can do it with several possibilities. You can do it with a balloon, but it's expensive. You can do it with your finger. I've seen some surgeons just opening the muscle, placing their ports, or you can do it with a scope. I learned this technique for a general surgeon 30 years ago. Okay, right. I was because I'm still doing hernia repair, and he showed me this in 1991. Okay, so it's easy to do for me, but do it as you prefer, or with a finger or with a balloon. But go in this space. It's really fantastic. And if you have problem, for example, if you have leak or if you have hematoma, it remains in the prevesical space. It won't go in the abdominal cavity. So the outcomes are totally different.
Thank you.
Sir, two questions. With the robotic approach, do you still go extraperitoneal or do you prefer transperitoneal?
No, with robotic approach, I'm doing trans because I play 6 sports, okay, and I teach this in the university hospital, and sometimes in the pre-physical space they are lost. They are looking for their instruments, so I don't want to have any injury of the bowel and so on. So for university hospital with the robot, I'm doing trans, but I'm just detaching the lateral part of the bladder.
Right.
Because my assistant is on the left, so I detach only the lateral part of the bladder. I get in the space, and I'm doing like a pre-physical space. I'm not detaching totally the bladder. Okay?
And if you have hematomas when you've done an extraperitoneal approach, does it cause a bigger problem than when it is through the transperitoneal approach because of absorption of the hematoma? Do the hematomas then get stuck over there and get infected, or is that not a big problem?
Can you repeat the question?
Yeah, so when if say for example after an extraperitoneal prostatectomy, which is done laparoscopic, if you have a pelvic hematoma, does that hematoma then not have a space to get, say when you've done it transperitoneal, it can get absorbed through the peritoneum? With the extraperitoneal approach, do those hematomas then get infected and cause problems?
So that's right. That's also a problem because a solution is that it remains in the previous pre-physical space, but when you are transperitoneal, the hematoma will go in the abdominal cavity, and sometimes they have no more pain because sometimes you have hematoma, sometimes you have to rego. Personally, if I have to rego, I rego pre-peritoneally, just do suction, remove, and most of the time you don't find anything. The problem is most for the lymphocell. We have more lymphocell with the previous, but we are doing less lymph node dissection than we were doing. And if I have lymphocell, I will go directly transperitoneally, and I will create a windows in outpatient surgery, just a big windows, and the lymph goes in the abdominal cavity, no drain, and it's okay.
Thank you very much.
Last question.
Dr. Eric, a fantastic lecture, and I was there in the surgery. Again, another great treat to watch you. What would be the learning curve of your, if you want to put it for the audience, what would be the typical learning curve if somebody has to venture into an extraperitoneal radical prostate 1? And secondly, what are your contraindications when you would say, no, I will not do extraperitoneal prostate?
So the learning curves, the problem of the prostate is a very difficult surgery. It depends, totally different than the kidney. Partial nephrectomy, you take your resident, 10 partial, you will be free, quite. Prostate, it's always different because it can the size of the prostate, median lobe, the tumor. So it's very difficult to say. But I think you need minimum 50 case to start to be okay. But minimum. But I think you feel confident at 100 and you feel perfect at 500. It's my. Now the second question was: is there any contraindication? For me, no. Even if I have a previous mesh for hernia repair, I will try. I will get in this space. If it's totally stick, I stop. I go in the abdominal cavity, and then I detach the bladder, and it's the same. But I always try. Okay?
Thank you, sir. Thank you so much for the wonderful lecture, and especially for finishing it on time. I would like to thank the chairpersons, and would like to welcome the next session's chairpersons, Dr. Giridhar Bora, Dr. Ajit Sawant, Dr. Rohit Joshi, Dr. Altaf Khan, Dr. Abhijit Patil, Dr. Prashant Raj Garg. We start with the next laparoscopic surgical cases, and over to the chairpersons.
Auditorium?
Yes, hello.
You are now live with back to Dr. Arnold.
Hello, am I audible, sir?
Yeah, you're audible.
So I just want to show that we have done the cystectomy part.
Yes.
Just show you
Mm-hmm.
more towards the apical portion. So we have done the lymph node dissection on the left side, and we are doing the right side. I'm just showing our template on the left side. Then you can continue. So this is the rectum. One person can just put a finger, and we can show you that we have preserved the perirectal tissue all around.
Yes, we can see that.